Thank you for staying with us on Citizen Weekend, following news of a leaked internal memo from the U.S. State Department ordering an immediate freeze on all foreign assistance, with the exception of emergency food aid and military funding for Israel and Egypt. The question then becomes, what does this mean for Kenya? The move is in compliance with one in a series of executive orders signed by Trump on assuming office on Monday that ordered, among other things, a 90-day pause in United States foreign development assistance for assessment of pragmatic efficiencies and consistency with United States foreign policy. There was also an executive order for the withdrawal from the World Health Organization, which will see the U.S. cease to be a member by this time next year, barring any legal challenge. The WHO has, however, expressed a willingness to engage in, quote, constructive dialogue in the hope of averting the withdrawal and resultant financial blow. Trump having criticized it for its handling of the COVID pandemic and slamming its assessed contributions as, quote, unfair, onerous and far out of proportion. 43 billion Kenya shillings is the amount Kenya was to receive between October 1st last year and September 30th this year for its HIV response. As I mentioned severally in the last 30 minutes or so, we are joined by Dr. Mercy Mwangangi, and she is the Director, Health Systems Strengthening, AMREF Health Africa, as well as Dr. Sultani Matendechero. Perhaps many of you remember him as a unionist, but now he is the Deputy Director General, Ministry of Health. Good to have both of you here. So just in the last couple of hours, several developments. The World Health Organization says, yes, it has been formally notified of the US's intent to withdraw from its membership. And then we've also had Marco Rubio, the Secretary of State, issue, or rather an internal memo, which was leaked, showed that there has been an immediate freeze on all foreign development assistance, barring where there's situations where it concerns emergency food aid and military funding for Israel and Egypt. Is there cause for alarm? Should we be shaking in our heels, Dr. Mwangangi, tonight?
Thank you. Thank you, Olive, and thank you for having me. Is there cause for alarm? Yes. Yes, there is cause for alarm, because it's important to note that WHO as an organization is absolutely fundamental when it comes to protecting the world's health. And, you know, in all the new developments that are going on right now, one of the key things that most people agree on, most countries agree on, is that if we did not have WHO today, we would be creating it. So that's how important it is. If it wasn't existing, we would all be working as member states to ensure that it exists. And I guess what we need to then now focus on is, how do we ensure that WHO, as is structured today, is able to be strengthened, not weakened, not, you know, seized or closed up, or, you know, it needs to be operational. And how do we define that? How do we put in place parameters to ensure that WHO is able to ensure that we're all healthy, that we are protected from emergencies? And so, yes, there is cause for concern. It's important that all member states come together. There's about 198 member states who form the caucus that is WHO. So member states do need to come together. We do need to ensure that we strengthen the organization. We ensure that its mandate is clear. We ensure that its financing is clear, predictable, and sustainable. And then we're able to then also ensure that the expertise within the WHO Secretariat is able to work and serve member states.
But so, you know, I'm hearing you say, like, there's room for improvement.
There is room for improvement.
But let's get first Dr. Matendechero's sentiments on the same. I was listening to your immediate reaction right after he signed that executive order. You sat down with my colleague, Mary Mwoki. And, you know, just listening to what you said, you didn't seem too worried.
Yeah, actually, of course, the withdrawal of WHO is quite a major issue. The withdrawal of the US from WHO, because the US is actually the biggest funder of the WHO. So definitely the operations of WHO, if nothing is done, are really going to be affected. And WHO is an extremely important player in, global health in terms of, coordinating, public health emergencies, response and preparedness, and many other health programs. However, worry will depend on which stakeholder we are looking at. So, for example, myself, I have to be concerned because we have to look for alternative ways of being able to protect the public from this withdrawal. And that is something that we are already working on. That is something that we are going to deliver on, because it doesn't matter whether US withdraws or not, we still must make sure that the public is protected. Stakeholders like implementing partners will be worried because now the landscape is going to change. But for the general public, one of the things that we must ensure is that there is continuity of service. Whether we are changing, to look towards other, member states stepping up, or maybe looking for alternative sources of funding, those are things that we will have to get into so that we can be able to avert any crisis that is going to be forthcoming. But shockwaves, we will definitely have some of them, especially in the short term, even as we understand what the real implication is. Yeah.
When you look at HIV response, TB, malaria, NT, what are they called? Tropical diseases? The
neglected
tropical diseases. We have a lot of external funding that comes in. PEPFAR, the budget, I believe, for 2025 was 43 billion. The Global Fund, over 50 billion going to the National Treasury, as well as organizations such as AMREF Health Africa. Although the plan has been all along towards shared responsibility, where are we along that journey?
That's a good question, Olive, and I sort of want to piggyback onto what Matendechero said. When we talk about WHO, WHO is one of the big actors in the global health system, and there are many other actors, as you've named them, PEPFAR, Global Fund, Gavi, etc. It's important for us to see WHO as this coordinating mechanism that coordinates 198 member states. And why should we bother about coordination? We need to bother about coordination because when Mpox is detected in Kenya, it is the responsibility of WHO, one, to ensure that Kenya reports on time, and then that information is then shared with the 198 member states. So imagine a world where we don't have WHO. Imagine what that would look like. Who would coordinate us? Who would bring us together? Who would give us normative guidelines? Who would look at our essential drug lists? Who would look at pandemic responses and ensure countries are sharing information and responding? That's really, really important. And borrowing that same leaf, if we look at Global Fund is a coming together of public and private sector, organizations, philanthropy groups, investors, countries, to support the fight against HIV, TB, and malaria. One of the things we need to ask ourselves, are we doing well in the fight against HIV, TB, and malaria? Kenya has done fairly well. We've reached some good goals. We have different goals that we always call the 95-95 goals. Kenya has done fairly well. But guess what? We're still third in terms of epidemics when it comes to HIV in the world. And if you talk about 43 billion, and this is just for Kenya, this is our cooperative agreement with PEPFAR for Kenya, scale that out to Africa, scale that out to Southeast Asia. And then let's add in all the different crises that the world is facing, the debt situation, the COVID shocks that we're still recovering from. Now is not the time to make some of those big dents. However, it is important also to remember that countries can only move forward if they finance their health systems in a larger proportion than they're doing right now. In other words, the Bible verses and preaching of self-reliance is so key right now. Relying on our domestic resources is what is going to move us towards universal health coverage. The question then needs to be, how do we manage that transition? And how do we make it sustainable? And how do we ensure that as we get into that transition of trying to, channel out external financing, that we're doing it in a manner where we don't lose the gains in HIV, TB, and malaria? Yeah.
So I will throw that question to Dr. Matendechero. How do we do that?
Yeah, so I think maybe just picking up from where Dr. Mwangangi has brought us, it's important for us to look at this whole scenario objectively in terms of What does it mean? First of all, when you look even at the funding model for WHO, there are several funding streams. There is what we call the assessed contributions for all the 196 member states.
So is that where the 18% from the US comes in?
So the US actually, apart from the assessed contributions, which are based on GDP, they also put in voluntary contributions. Yeah? And the bulk of those voluntary contributions, roughly about 1 billion, goes to what is called specified contributions, where they say this money is going to go into this particular project and it has to be done within this particular time. So that one cannot be taken, there's no flexibility. It has to go into that particular project. So we are looking at about $1 billion that would have gone into specified projects that is out. And then there is also about $47 million that goes into what we call contingency funds for emergencies. So that, like, for example, if there's an outbreak of Mpox, WHO is able to quickly, within a very short time, actually they usually say within 24 hours, you are supposed to quickly be able to respond. So it supports that in member states. And then now there is this part of the vote, which is a bit flexible, which now is called the core voluntary contribution. So the US is going to end up pulling out, because for WHO, if you look at the executive order, with regard to WHO, they are actually pulling out completely. So they are going to pull out about $1.3 billion. So that is quite a lot of money. Now, when you come to the bilateral arrangements, like now the PEPFAR and so on, which are now directly with the other countries, then you realize that those ones, they have just put a freeze for about 90 days. Now, what we are not understanding as at now is whether that is going to apply to already existing commitments or it is going to now apply to new funding arrangements. So if it is not going to apply to existing commitments, then at least we might have time to be able to proceed with our programs. Number two, within 90 days, the Secretary of State, Marco Rubio, is supposed to come back to the president with recommendations. And what they have been told to do is very specific, because these funding mechanisms should align to the president's foreign policy. You see? Because now, with withdrawing from WHO, and in the same executive order, and that's why I'm saying, for me, we are not completely worried, because in the same executive order, as they pull out of WHO, they're also saying, identify alternative partners, internationally and locally, who can now take up the responsibilities that WHO was undertaking. Of course, it is not going to be the same, but within the 90 days, what we are now expecting them to do is to harmonize so that there is no duplication, there's more efficiency and things like that. It will not be the same, because WHO, we are going to now interfere with that coordination aspect of WHO, technical assistance that comes from WHO. So it is going to be different, but then I think what we are expecting is that in 90 days, we'll see more bilateral engagement as opposed to the multilateral platform that is provided by WHO.
So when we're talking about like bilateral arrangements, right, the 90 days, to which the 90 days applies a reassessment, PEPFAR, this 43 billion, it goes to what? ARVs, condoms, what does it cover, Dr. Mwangangi?
So the 43...
Practical terms, basically, what are we saying?
So 43 billion is supporting the procurement of commodities that we use in Kenya. When we look at ARVs, there's a whole range of different types of ARVs, from different kinds of treatment regimens. Those are procured through that support. When we think about all the capacity building efforts that go into introducing these regimens in the 13,000 health facilities we have in Kenya, with almost 100,000 staff, all those need to be trained, and that money sits there. When you look at response money, when you look at family planning money, when we look at resources that help us in ensuring that we're looking at access to different, health system building initiatives, such as ensuring our health information systems are working, ensuring that we are tracking our TB default cases, ensuring that we are following up our mothers who may be HIV positive and have missed their ANC clinics. So it's actually tremendous support that is so vital to the work workings of our health systems, both in Kenya and in Africa. And Olive, I hear you when Dr. Matendjetera says he's a bit, you know, half concerned and half not concerned. But remember, for our own country, Kenya, for every 1 shilling we're spending on debt, we're only spending 0.3 on health. Now imagine pulling out 43 billion. What does that leave with us? You know, what does that leave behind? And so what we are really championing, really, at the end of the day, what are the alternatives? What happens within the 90 days? It's important for governments to come together to be able to reassess their health programs. It's important to remember at the end of the day, you must use domestic resources. We must really now dig deep as countries and use our own exchequer financing to support health. That is absolutely pivotal. And then member states, communities, civil society organizations need to come together. We perhaps need to reassess, how are we actually financing health systems in Africa? Are we having wastages, leakages that need to be controlled for? And how do we actually leverage this new opportunity provided by the new American administration to have more effective health systems, to have more efficient health systems? So there are opportunities here, and that's some of the work that we'll be doing in AMREF, particularly in Kigali in March. We are convening the whole of Africa, and this will be one of the things we'll be discussing. Yeah.
All right. Dr. Matendjetera, of course, there are people who are listening who rely on these ARVs, who, you know, depend on these systems. And when they hear there's a 90-day freeze, they wonder, you know, will this set us back with the 90, you said 95, you know, target? Should, you know, because I was reading an article the other day, and your DG, the Director General, responded and said, we'll be looking at other arrangements, maybe the European Union, you know, the Bill and Melinda Gates Foundation, but you know, PEPFAR, if it were to not return with the same terms, would be a big blow, because this has contributed significantly to where we are since 2003.
Yep.
Yeah, so maybe one thing that I'd like to also just bring to your attention is that sometimes these are things that we foresee. For example, when the US went to the elections and Trump won, we already had an idea of what is going to happen. Because you see, this is now a conservative government. It is not a progressive government. So we are already expecting that there's going to be cutbacks on issues like family planning, you know, and other related issues which conservatives don't support, you know. Whereas the progressives would have come in strongly, you know, with some of these programs, the conservatives will cut back on them. Now, the same thing, just as we were anticipating with the WHO. So already we are looking at alternatives, and when the DG was talking about some of those, you know, private funding, philanthropies, and so on, and the European Union also has come in quite strongly when it comes to some of these funding mechanisms that I was talking about, you know, the voluntary contributions and so on. We are seeing the European Union is really putting in quite a bit. There is an interest in ramping up the contributions. And even as we talk about this pullout of the US, let us also remember that the WHO has actually formally requested the US to reconsider. So that is a process that will go on. And it is not just the WHO only, because there is going to be very many other channels, even bilaterally, by countries. Number three, the US itself also has to make sure that it is taking care of its health security. Because they have to protect themselves from external, you know, infections coming in from external sources. So these are also dependent on the integrity of the global health system. So it is a very complicated situation where we can't just say, even the US itself cannot just afford to pull out and sit back.
Because they have also pulled out where negotiations on the handling of pandemics is concerned, right?
Yes,
yeah, actually, that is one of the big setbacks, because as we speak, the U.S. now has, you know, the Secretary of State has been instructed that the U.S. will pull out of all the ongoing negotiations on the pandemic treaty. we concluded the international health regulations, which actually are that is the tool that helps us to prevent international spread of disease. I was vice chair of that process at the WHO, the global amendments. So the president has said they are not going to be party to those amendments, at least as we finished, because we amended the regulations and the World Health Assembly passed those regulations last year, so they are already in force. But the treaty is still being negotiated, so they have pulled out. So those are things that we are going to really be looking at. And then maybe just quickly to touch on the issue of looking at new ways of being able to put in sustainability.
Yes. Actually, you've preempted my last question tonight, so you could start and then you finish.
So you can already see that Kenya is really working towards, this is something that was anticipated even from the beginning. It was part and parcel of the partnerships around funding, you know, the foreign assistance that came. That within a certain period, we expect to see, you know, countries picking up this responsibility so that we have sustainable mechanisms of being able to support these public health programs. But then we have been slow. Now, the good thing is that Kenya is already on the front line. You can already see we are coming in with a lot of initiatives, like the Social Health Authority, where we want to be able to generate a lot of money, because you can see the figures you're talking about, they are huge. And when you see the policies that are being put in place, is actually to be able to generate that money, to be able to make us self-sufficient so that we can stop relying on foreign funding. There are other opportunities that probably we'll be looking at, so that instead of looking at external philanthropies, we can also look at domestic philanthropies. We also have billionaires here in Kenya who can plug into the public health space. So it is something that, you know, we are already working on. We are having a few challenges, as you know very well, but then in the fullness of time, we expect that we are going to be able to move to steady up and to be able to now increase the injection of domestic resources into public health.
All right. Yeah. Dr. Mwangangi, you had mentioned a figure of 0.3%. You know, we have the Abuja Declaration, which is 15% of the total government budget. But then there are those who say 15% of what, an elephant or a chicken. I'm quoting Dr. Githinji Gitahi. So moving forward, when it comes to financing health, which way should we be heading?
So I think, again, there's an opportunity right now. Number one, as Sultani has said here, DRM, domestic resource mobilization. Governments must be accountable for the health of their citizens. There is no shortcut around it. The last time we looked at the Kenyan figures in terms of how we spend our health money in Kenya, we have about, let me say, 40% that is financed by government, and that's good. That's an improvement. 15 years ago, it used to be around 15, 20%, so that's an improvement. But then we also have Kenyans digging into their pockets, about 30%. That's a lot of money. And we're talking about 500 billion Kenya shillings. It means that households have to go into their pockets, remove their money, and try and get health care. That's not acceptable. And then, of course, we have external financing. It means organizations like PEPFAR, European Union, foundations have to support the Kenyan health system to a tune of 26%. That equation, 40, 30-something, 26, needs to change. And the levers of change start with government. So we have to support domestic resource mobilization initiatives. AMREF does support those initiatives. Foundations have to put into money to ensure that government actually mobilizes its own exchequer financing and protects its citizens. Beyond that, perhaps we need to relook at how we pay for health. Perhaps we need to put in conditionalities. Perhaps we need to say that we shall pay for results as opposed to just putting in money in an input-based system. Perhaps it's about time Sultani Shah was able to pay for quality of health services and not just the provision of health services. And so if a hospital provides a mother with a delivery service, can we make sure we reward the hospital that provides a quality delivery, not just a delivery? So there's some few tweaks here and there that we can put in place in how we pay for care. It's about time we look at the private sector and truly saw them as a partner that can really come in with some form of catalytic funding. It's about time we looked at investments, looked at social impact bonds, looked at ways of trying to put in place cost recoveries and profit incentives beyond providers in our system. So it's time for change, for sure.
All right.
Yeah.
Thank you so much for your contributions this evening. I know there's a lot to go into just listening to all the options you've laid out on the table, but perhaps this provides just the opportunity to get into all of that. But Dr. Mwangangi says no shortcut, and Dr. Matendechero says let's wait and see how this plays out. It's not necessarily all doom and gloom. So thank you very much, Dr. Masi Mwangangi, Director Health System Strengthening, AMREF Health Africa, and the Deputy Director General, Ministry of Health, Dr. Sultani Matendechero. Thank you for joining us on Citizen Weekend. We take a break, but there is still more coming up.